So moving on to Dr. Beck. So Malene is an associate professor in clinical nursing at the University of Southern Denmark and head of research, #WeDoCare Research Unit, Children and Adolescent Department, Zealand University. She is a clinician researcher with recognized expertise in pediatric care, ethics, and the intersections of empirical research, nursing theory, and philosophy. She leads several research programs advancing clinical nursing care for children and their families. Her work bridges practice and academic inquiry with attention to children's lived bodily and relational experiences in healthcare. Her work is grounded in life world perspectives using empirical methods such as interview, observations, and narratives to explore experiential, relational, and ethical dimensions. Without further ado, I pass it on to you, Malene. Thank you again for being here.
Thank you very much, Michael. And thank you for giving me the opportunity to speak today. So as Michael said, my name is Malene, or Malene, as we say in Danish, and I'm an associate professor. And right now I am at the Children's Department. I'm actually sitting here right now. It's in the middle of night in Denmark. And today I'm going to talk about one of my favorite topics. And I should warn you, because if I get too excited about this and my English becomes difficult to understand, please just let me know. So I just want to start off with this poem. I recently came across it. It says, "They say we live in places, but I've learned places live in us. They cling to our tongues when we speak, to our feet when we walk away, to the husk between memories and maps." So this poem actually stayed with me, perhaps because much of my life in healthcare has taught me that spaces is not around us, it lives into us, in our gestures, in our breathings, and in the way we dare or don't dare to speak to one another. So before I turning into my talk, I want to say a few words about the place that I speak from. My understanding of space in healthcare didn't begin in books. It began in the neonatal care as a nurse. And in the neonatal intensive care unit, space is never just a backdrop. Light, sound, alarms, the way a chair is placed, how we speak or move, all of it can actually affect a premature baby's breathing, heart rate, even brain development. So too much light, too much noise, too sudden a movement, and the child becomes unstable. So we learn to lower our voices, dim the light, shield the incubator, and invite parents to come close, skin to skin, so they begin to become parents in place that is both technical but also very human. This way of thinking that space shapes us, that bodies and rooms are connected, has stayed with me. So later, when I, as a nurse, began working in the neurological department, I've noticed something. Here too were people very impacted sensorially due to their diagnosis. Stroke, Parkinson, dementia, migraine, tumors related to cancer were all diagnoses that could challenge the sensory perception, balance, or even orientation. And yet the same attention to space, to light, sound, pace, touch, was not always present. So it made me wonder, why is spatial sensitivity considered crucial for premature babies or infants, but less so for adults whose sensory systems are also vulnerable? So these questions were the ground for my research and is the ground for my talk today. So my intention is to provide an experiential lens to how space and place can be experienced at hospitals, and I will do so through 3 empirical studies. The first one is called Quiet Please, the second one is called Becoming an All-Mate, and the third is called Hospitality. Across these studies, I want to show that space is never just a backdrop in healthcare. It is part of ethics, the relationships, and the lived experience of care. So before we move into the examples, the empirical examples, I'd like to take a step back and set the scene. to share some ideas about space and places that we view in the Nordic countries, in a Nordic context. So this is Denmark. We are a very, very small country. We have 5 million people, and one of the 5 million peoples are living in our capital of Copenhagen. So what is relevant in this talk to know is that Denmark is a country with a comprehensive healthcare system. We pay around 50% of our salary in taxes, and healthcare is accessible for all our citizens. And there's also a large budget going to healthcare sector and the renovation of it. So in Denmark and across the Nordic countries, there has been an awareness of design and aesthetics. This awareness shapes how we build our cities, renovate our public spaces, or even how we design our surroundings and eat our meals. Some call this a Nordic aesthetics, a way of thinking about space that values light, simplicity, balance, and calmness, bringing nature in, using handcrafted furniture, and so on. This is often described as a kind of cultural atmosphere. The New Yorker even called it the promise of the simple, balanced life. In Nordic design thinking, it has often been suggested that the goal is not only beauty or prettiness, but it is to create atmosphere that invites presence and belonging. In research, this awareness or the why of decoration has also been linked to ideas of democracy, equality, and everyday well-being. For instance, studies of Danish design culture have shown how attention to atmosphere and form reflects broader social ideas about accessibility, modesty, and collectively belonging. Well, to me, this tradition also raises a number of questions. How much such a cultural value influence the way we think about care and about healthcare environments? Perhaps we should ask ourselves, if atmosphere and aesthetics are so important in our everyday life, what happens when we bring these cultural ideas, this Nordic aesthetic, into healthcare? So in Denmark, there has been also an increased awareness of renovating and rebuilding healthcare. This has been seen in new legislation, reforms, and reorganization of buildings in healthcare. The questions for the politician has been, how do we actually transform healthcare settings for the better? So while we've seen new hospitals being built and others renovated, much of our healthcare infrastructure still reflects the architectural ideas of the 70s. Concrete, functional, and efficiency. These are all pictures of hospitals nearby that actually illustrate how the hospitals look like. These are spaces that were designed for another time, and today it raises important questions about what kind of spaces we actually need to support healthcare and recovery. So we have seen a lot of new buildings and a lot of new super hospitals, as the politicians calls it, where they rebuild our hospitals. These so-called super hospitals are being built so they can actually invite for calmness, presence, and connections, in theory. Here you can see some examples from the Hospital of Gødstrup. This is a local hospital outside the country. The materials are, according to the architects and designers, intentionally created to create atmosphere through light, wood, and an open spatial composition. Here you also see a picture of a birthing room where families can choose the kind of atmosphere that they would like to give birth in. A forest, a beach, and so on. And here is a picture of a new built church, also built with inspiration to wood, forest, and water. Another example is the Mary Elizabeth Hospital in Copenhagen. This is the mother hospital of all our hospitals in our country. This country has received several awards for its architectural design and the way it integrates patients into the design process. The architects have worked with the idea that healthcare spaces should invite interactions and a sense of familiarity. On their website, they describe the concept as healing meets homeliness, which captures something essential about how design theoretically can support both physical recovery and emotional support. In other words, it's not just about efficiency and technology. They want to create a space that feels alive, responsive, and human, and not at least homey. So now I want to tell you a kind of a personal story. Recently, my son was very ill, and he had to be hospitalized. We were admitted quite suddenly, and there wasn't much time to think or ask questions. And we were admitted to one of these new hospitals. And I remember walking with him through the long, bright corridors. Everything felt very still. The sound of our footstep, the echo against the white walls, the smell of new paint, and disinfection. A nurse led us to our room, and when we stepped inside, it was completely empty. I took a picture of it. No bed, no chair, no furniture, just the light from the big window and the polished floor. Another nurse came in. She was very gentle and very kind. She told us that she would soon bring a bed and also a menu so my son could choose a ready meal for later. I asked for a chair because I understood that we were going to be there for days, maybe a week. When the nurse came back with a bed, she kindly said that she really wanted me to feel home, also my son. So we stood there for a while, not really knowing what to do. And then my son looked at me and said, "Where are we supposed to hang out?" And this is where we actually hung out. We were hanging out in the window because we could actually be together in the bed there. So what my son asked that day, where are we supposed to hang out, may sound very simple, but it's also a question about what the philosopher Martin Heidegger calls dwelling. Heidegger writes that we do not dwell because we have built, we build because we dwell. Dwelling comes first. It is a part of being human. And he also writes, spaces receive the essence not from space, but from place, which means a room is not truly a place until it gathers life, relations, gestures. And in the hospital, everything was newly built, bright, efficient, functional, very pretty, but there was no place to be. The space was there, but the place was missing. So my son's question was not only practical, it was existential. Is there a place for us to dwell here, to simply be? Heidegger says that to dwell is to be at peace within the free sphere that safeguards each thing in its nature. When I reflect on this, it is not to be complaining or critical towards our treatment. My son's treatment was carried out very fine and they were very kind. But it is to bring to attention that perspectives of spaces and places in healthcare are far more complicated than good or bad or decoration that are pretty. It is both really concrete, like having a chair as a parent to sit next to your child, but also very abstract as the concreteness of place asks existential questions related to how we might be as human when being hospitalized. So what this experience made me think of was, in a hospital, maybe this means creating places that safeguard the small human gestures like waiting, sitting, breathing, to be together without performing illness. So the thing about spatiality is that we don't even have a very good language for it, or at least Einstein would say so. We often use the words space and place as if they were simple and self-evident, but they are not. As Einstein reminded us, even space is not fixed. It depends on perspective and relation. And this raises questions for us, because if space and place are not stable concepts, how can we think with them? What ways of understanding space are available to us in healthcare? So one of the answers come from the philosopher Otto Bollnow. I have his very good book here. Bollnow makes a distinction. He says that space is openness. It is the sphere in which we move, act, and orient ourselves. Place, on the other hand, interrupts this openness. It is where movement comes to rest, where space gathers around a person, a body, or an event and takes on meaning. So in this view, place is not just a location on a map. It is where space becomes intimate, where it shelters or exposes, welcomes or excludes. It can be a hospital bed, a waiting room, a chair beside an incubator. Places become charged with meaning because something happens there. Care, a look, a talk, a way of being with another human. So if space is something we live in, not just something we build, then it also matters how it is built. So there's already a great deal of evidence showing that design really matters. We do know that access to nature and daylight reduces stress and supports healing. We also know that architecture can influence pain levels, infection rates, and even patient satisfaction. But even with all this knowledge, something still remains less explored. Because while EPD, evidence-based practice, and design tells us what works, it doesn't always tell us how it feels like, what it is like, the experiential point of view. And this is where human science more broadly can offer something different. Not an answer to what works, but an understanding of healthcare environment as a lived space, a place that's shaped and are shaped by our being there. So even though we know quite a lot about how design and evidence can improve care, in practice, things often looks quite different. Decisions are not always systematic. They are often shaped by leaders or leaderships, timing, and tradition. And when many stakeholders are involved, evidence can easily become inconsistent. It competes with taste, budget, and intuition. Well, coming back to how healthcare environment spaces and places can be explored, I promised you some examples of how I did some work. So let me head off to them. So these are empirical works that informed my reflections on spaces and places. What they all these studies have in common is a question. How does space take part in the neurological department, not as a backdrop, but as something that quietly shapes how life is lived in the hospital? The first study is called Quiet Please. It actually became very simple by following meal times in the neurological ward. Not to study food or diet, but to see how a meal actually takes form in spaces and places of the neurological department. This was important because we actually know that up to 80% of patients admitted to the neurological department have one or two eating difficulties. Difficulties that could be defined as recognizing food on a plate, guiding the hand to the mouth, chewing, swallowing, staying upright. All of this could require assistance, time, and rest between every bite. So to set the scene, try just for a moment to think about the last time you had a very good meal, a good meal. Maybe you shared it with a special one. Maybe it was a meal that you felt in particular was at ease, where you could sit for a while, meet a friend, taste the food, talk if you wanted, or not talk, where eating did not require effort, coordination, or help. This was not always how it looked at the neurological department. Here, the mealtime was quite different than the picture I just wanted you to picture in your, just wanted you to picture. This picture is actually of a mealtime at the neurological ward where I worked. I asked the patient and the staff, where should I be if I wanted to take part of a meal? And they couldn't answer. I was interested in the concreteness of a mealtime spaces and places. What is it like for a sensory disabled person to eat at a neurological department? That was the question to me. And I should add that the people and the patients in this picture have given consent to that I can use it. These are few of the voices I collected during the study. Quiet, please. When I listened to these voices, I noticed that they were not only speaking about food or appetite, they were speaking from inside a moment where the mealtime, the body, and the space were intertwined. The man who says, "I'm not hungry, I've just been told I'm not allowed to drive for 6 months." He sits at the table in the corridor. His meal is not only interrupted by bad news, the entire meal space collapses into something else: uncertainty, loss of independence. The relative who says, "I'm not really sure how you are supposed to stand in line here," is not just confused about the procedure, she's asking a spatial and relational question. Where do I belong here? Am I allowed to be close, or should I stand back? Space here is not neutral. It organizes who may take part in care. And the patient who says, "I like it when the window is open, then the food doesn't smell so much like hospital," shows something very small but really deeply human, that sensory atmosphere matters. Fresh air, light, family photos, and all of this makes eating more possible, or maybe even more human. These are small sentences, but it's also concrete examples because they give insights to that meal times are not only about nutrition, they are also about space, how we exist in it, and how care is felt. So this is another example, a note from my observation from the meal trolley where I stood for 3 months. What I want to draw attention to here is not every detail in the scene, but how the space of the ward becomes visible through meal times. A meal doesn't only take place in the ward, it quietly reshapes it. A corridor becomes at once a passage, a working place, and for a short time, a place where people eat, wait, and are present to one another. Again, in this shift, the mealtime becomes more than food. It becomes a spatial situation made up of sound, light, movement, smells, interruptions, and nearness. These elements give the space a particular atmosphere. So across all these studies, some things have stayed with me. First of all, mealtimes are existential and spatial events. They interrupt the hospital rhythm and create a small pause. Secondly, meals always happen somewhere, and space is never neutral. A bedside, a corridor, a day room, light, noise, footstep, interruption, furniture, and other bodies all affect how a meal is felt and are experienced. These elements decide whether eating is possible, comforting, exposed, or invisible. Third, space carries an ethical tone, maybe even a claim. Not through like official rules, but through small gestures, like drawing a curtain, pouring cream over strawberries. These are quiet ways of saying, you have a place here. When those gestures are missing, the opposite is also felt and experienced. So how can we even think of this? Boll reminds us that human life is always special. We are always in some relationship with space, and this relationship gives space its meaning. When we look at mealtimes in the hospital through this lens, they are not only about food or timing, they show how time, space, and people come together and create a lived place, even if only for a short while. The meal does not happen outside of a space. It takes form in it, in a corridor, by a bedside, in the presence of others passing through. And it is this relationship between people and their surrounding that gives the mealtime its character. So after the study of Quiet Please, where I explored mealtime spaces and places, I learned that there was something important about being in a space at the neurological ward. We also learned that not all patients were able to find rest within the walls of the hospital, especially at the neurological ward. For those who were able to leave their beds, we observed that they would often walk out the department to find rest, or even leave the department entirely and find some place at the hospital to be while being admitted. And this led to the next study that we call Becoming a Normate. And when I say normate, I don't mean it like in a romantic sense, but in a very practical sense. patient who remained in the hospital but kept moving from place to place within it because staying at one spot in the neurological department became too difficult as the space kept shifting around them. I followed some of these patients hospitalized with some kind of neurological disease and saw how they were able to move around. I was doing alongside interview to explore hospital spaces and places in situ in this situation. I followed them with a small microphone and asked them if they could show me the place they would go to and why it mattered to them. They took me several places, to the toilet, the hospital shop, the parking lot, the basement, under a tree outside, and to a quiet corner at the hospital. Small places that were where the intensity of the hospital was more softened. And here is some of the examples of what they told me. Sometimes I walk out the parking lot just to get out. When you have been here for a long time, you can't help feeling really sick. You can feel trapped in the negative environment. It's about a particular atmosphere being present. Then it can be helpful to just sit at the bench outside, watch the wind or the trees to get that peaceful feeling. Another one said, I also know a little about the basement down there because I've been sitting there and then opened one of the doors to the outside. It's almost like a refuge. I sat there a lot while I was in treatment and cooled down. So these descriptions draw our attention and raises some questions. What we might ask was what these places where the patient would walk to, the bench, the basement, the tree, what opens for those who actually find these places? What happens when one steps outside, even for a moment? And what kind of nearness to the world becomes possible there? So as I walked with the patient, I didn't just notice that they changed location because it was quite difficult in coming to rest at one place. Several patients described how no space in the ward really allowed them to settle. The average for their admission at this department was 7 days, sometimes even longer. They had a bed and they also had a physical place to stay, but they didn't feel held by the room. It was a gentle but persistent feeling of not quite belonging anywhere. So this brought me to the notion of placelessness. The philosopher Christian Norbert Schultz, he writes that placelessness is the loss of one's foothold in existence, and that to be at peace with yourself, we need to be oriented and to belong to a place. And that was what I began to see. Not patients who were restless, but patients who lived with a subtle spatial unease and who moved because no place offered rest, orientation, or a foothold. So by reading Norbert Schultz, a few reflections became clear to me. When people are attuned to a place, they can sense its rhythm, whether it lets them settle or keeps them on ease. Human beings need existential footholds, and this is small points of orientation that allows them to feel present, connected, and not adrift. When these footholds are missing, a quiet form of placelessness appears, not dramatic, but a subtle loss of grounding in existence. So what does placelessness look like? So let's just stay for this for a moment. This is a story about Eric. The story is about Eric, who is a man with a physical disability. He has aphasia after a brain tumor. During a walk together, he shows me a shared room. It is actually a toilet in the department. And he says with very great effort, there is no privacy here. We can't even go to the toilet on our own. So this moment gave insight to something essential to me. Eric is not just showing me a room, he's showing me the absence of a room, the lack of a sacred place, or space, if you want. He gives insight to what it's like to need a place where he can close the door, breathe, gather himself, and simply be a person. Here, placelessness is experienced as an existential exposure. There's no boundaries between the private and the public, not here in the hospital. No door to close, no space to belong. Here's another example. Where Eric lacked a room, this is an example of Anne who lacked something slightly different. The story is about Anne, and she says that she feels naked without her earrings, which she wasn't allowed to keep in the hospital. She says they are a part of her, and that without them she misses something that reminds her of herself. So where Eric lacked a place, Anne lacks a compass. She's not without walls or a bed or a chair, but without something that orientates her, something that connects her to herself. Her experience points to another dimension of placelessness, not the absence of space itself, but the absence of belonging, recognition, and identity. So as an afterthought, both Eric and Anne showed us that place is not just physical. It is emotional, existential, and relational. A place becomes a place. A space becomes a place when it allows us to be someone, not just somewhere. Without this, we may become nomads inside ourselves. So this is another picture from the department. What this slide points to is that space is never neutral. A room just does not just contain us, it also addresses us. It speaks quietly through its atmosphere. No space is empty. Every room is saturated with something, with trace of what has happened there, with expectations, routines, culture. And that something affects us, even before we can find words for it. As Van Manen, he writes, lived space is largely pre-verbal. We don't think about it, and yet we feel it. So Bollnow, he will call this the Stimmung des Raumes. That is German, but in English we would call it the mood of the space. And he reminds us that mood is not only inside us, it lives between us and the world. It belongs to the space itself. So if you look carefully at this picture, what do you see? It is simply a table without no chairs. As a nurse, I would often say to relatives, you're welcome to stay as long as you want. But the room says something else. There's no chairs, no place to sit, no invitation to stay. The space communicates the opposites of my intention as a nurse. So this is another picture. What do you see? I took this picture after a woman told me about the day she entered her husband's hospital room and his bed was gone. In that second, she thought he would die. He had died. He had only been taken for an MRI scan, but no one had told her. Since that day, even though he recovered, she still saw the absence of the bed when she entered the room. The space holds the memory. The body remembers. And so the question becomes, how do we experience the wordly or unwordly moods of certain places? And what do our hospital spaces silently communicate to us, even when we say nothing at all? So after conducting the Becoming an All-Mate study, we, the management, the clinician, and my research group asked ourselves, how can we respond to this? What do we do with our knowledge? And this became the hospitality study. In this study, we asked a simple but a very difficult question. What does hospitality look like in a hospital? Not as a service, but as a kind of a comfort. Hospitality like a welcome. I welcome you. This was related to what the word hospitality actually means. It comes from the Greek word welcome. And if we look back, care and place has always been connected. In the ancient Greece, healing temples like the Asclepia were placed in nature with fresh air, views, baths, art, and even theaters. Healing was not just treatment, it was about dwelling in an atmosphere that supported life and well-being. And in nursing, Florence Nightingale said something very similar almost 200 years later, 200 years ago, that nursing is about arranging the environment so that nature can help the patient heal. So we asked, what happens if we create small places inside the ward, places to sit, pause, dwell, and even just be for a moment? So I brought some pictures, but I brought some pictures of the tableaus that we created at the department. We had several of these tableaus at the department, and we called them dwelling places. And pictures doesn't really show the atmosphere, so we actually made a short YouTube video, and I provided the link if you wanted to see any further how it looked. We worked with an artist and a designer, and together we created these tableaus. It was small places in the ward where patient, relative, together with staff could sit down, pause, and just be. They were not only decorations. We thought of them as invitations to dwell. We even made a reading corner. We used what we had already, furnitures from the ward, and added soft colors, flowers, and natural images. Very small things, but we tried to make the environment more welcoming. But to see if hospitality, we wanted to do this to see if hospitality could become a part of an everyday life, a kind of approach to how we wanted to work. And we wanted to communicate, you are welcome here. So after creating these small tableaus, like gentle invitation to dwell or to pause, we asked, does this matter? Does anyone notice? And yes, they did notice. But the strongest impact was not only on the patient, but also on the staff. I brought some quotation here, but what the patient actually described was like feeling they felt they were being seen. But what they really wanted to point out was that the thoughtfulness in their environment was felt very strongly. It was like if they said, if you can take care of me in the environment and be thoughtful, then you can also take care of me medically. That was surprising to us. So Bolnow writes that stillness is not the absence of sound, but a pause in the ongoing demands of the world. In our study, patient described something similar. Not peace or beauty in a sentimental way, but brief moments when the hospital rhythm held back for a while. When they were not being measured, instructed, or addressed, this kind of stillness often came from a very practical things. For example, being able to switch on the light above the dining table themselves or adjust the brightness according to the time of a day. A simple dimmer, but it meant that they did not have to wait for staff or ask for help. They were not only patient being cared for, but people able to influence their surroundings, even in small ways. So, why even bother? Why even bother about hospital spaces and places? Why does these matter ethically? So now I want to bring the attention to a Danish philosopher called Knud Ejler Løgstrup. He worked with ethics and human existence, and he reminds us we never meet another person, another human, without holding parts of their life in our hands. He also says that we are not detached observers of the world. Our senses bind us to it. This means that, as I said, space is never neutral. It is a part of the ethical relation between human beings. For Løgstrup, space and place are not about beauty or decoration. It's about how the world addresses our senses, how space can support trust, hope, and care between people. When we look at this picture, the woman holding her baby, we can see care and closeness, but we can also see how fragile it is at the hospital. A family trying to exist in a space that is not made for family life. So Løgstrup's ethical question becomes ours. If we hold part of another's life in our hands, do we also hold responsibility for the space around them? And if so, how do we shape place, and how does place shape us? So back to the future. How do we actually move on and move forward? Maybe not by inventing something new, entirely new, but by remembering something we already knew. Maybe we should think of healing or recovery as all is also about how we are placed in the world. In this room, the new hospital, this is from the Mary Elizabeth Hospital. This is one example, a step forward, yes, but perhaps also a question: will space like this also allow treatment and humanity to coexist? Or are we in danger of building hospitals and forgetting what makes us human? There are three things that I hope that you will take with you. First, human life is always lived somewhere. We don't exist in the abstract. We exist in places. And those places shape how we think, how we feel, and how we relate. Secondly, we don't just move through spaces. We dwell in them. We find orientation, safety, memory, and meaning in places that allow us to be. Third, this means that care is not only a clinical act, it is also special. It happens somewhere, and that somewhere matters to people. Spaces influence how we are able to be human. Beneath the surface of our healthcare environment, there are things that we don't always notice, but these things are always felt, endured, and lived. What we experience in hospital spaces and places are related to routines, gestures, hierarchies, policies, and culture. So if we want spaces that geniusly make room for being human, maybe we need to make the invisible visible. It is not only the walls that we might need to rethink, but how we are within these walls. Perhaps it is our way of seeing space and place in healthcare that needs rethinking. What if healing is not only a clinical act, but a way of being with someone in a place? So rather than asking whether hospitals can feel like home, the real ethical question, at least to me, is what kind of human encounter do these places make possible? If space is never neutral, if it shapes how we relate, listen, touch, withdraw on, or approach other humans, then we might need to ask how ought we to be within these places so that people can feel safe, recognized, and still be human. And just as importantly, do the space we build and work in allow us to act ethically, or do they need to, or do they make it harder to be kind to people? So I want to end where I started, not with an answer, but with this poem. They say we live in a place, but I've learned place live in us. They cling to our tongues when we speak, to our feet when we walk away, to the husk between memories and maps. A place is not just ground and coordinates. It is breath, a heartbeat drawn in dust, a name whispered in the wind, and to be lived is to leave pieces in yourself, in every corner that ever called home. So the poem reminds us places don't just hold us, they stay in us. Hospitals are not homes, but they become part of people's inner landscape. They are remembered in bodies, in silence, and in words. So the question is, when people leave these places, hospitals, what will stay in them? So I just gathered a couple of thinkers on. There's a lot of a quite broad domain of place and space theory, but I gathered some of the thinkers that I like to read. If you want some of the books here, you will get quite a very depth on what it means to think about spaces and places. And I just need to add that I don't have any conflicts of interest. And I created some questions that we might want to dwell on together, because I am curious if any of this will sit with you, or or you have any reflections or new openings that I haven't thought of. So thank you very much for having me and letting me to talk about this topic. And I'm happy to take your questions.